Auzubillahiminash-shaytanir-rajim. Bismillahir-rahmanir-rahim. I am Professor Muhammad Badar Bashir, and is regarding the chronic complications of the diabetes mellitus. As we have discussed in the previous lectures about the acute complications like hypoglycemia and diabetic ketoacidosis and hyperglycemic hyperosmolar state. In contrast to that, these are the complications which are developed over time. Uh, we can classify chronic complications into macrovascular disease and microvascular disease. Macrovascular disease is distinct to type 2 diabetes mellitus, especially because it is a part of metabolic syndrome, and their basic pathophysiology behind the development of macrovascular disease is atherosclerosis. And atherosclerosis is not solely dependent upon hyperglycemia to take place. There are certain other factors like hypertension, uh, hyperlipidemias or dyslipidemias. They actively take part in the pathogenesis of atherosclerosis. And macrovascular disease includes the cerebrovascular accidents, cerebrovascular disease, cardiovascular disease like myocardial infarction or angina, then peripheral vascular disease. All of these are dependent solely upon the development of atherosclerosis into the big vessels. And the pathophysiology of atherosclerosis depends upon definitely uncontrolled diabetes, hypertension, dyslipidemias, and this complex in which the pivotal role is played by the insulin resistance is overall called as metabolic syndrome. Diabetic foot primarily is a combination of macro and microvascular disease because both the peripheral vascular disease and neuropathy takes part in the development of diabetic foot. So this is a sort of combination of macro and microvascular diseases in diabetes like as that of erectile dysfunction. When we talk about the microvascular disease, which will be the main topic of our discussion in this lecture and the next lecture, this lecture particularly will cover about the pathophysiology and pathogenesis of the microvascular disease. Macrovascular disease is not the scope of our these lectures because they will be dealt with separately according to the system. So microvascular disease includes retinopathy, nephropathy, erectile dysfunction, and peripheral neuropathy. As I have mentioned that like diabetic foot, erectile dysfunction is also a combination of macro and microvascular disease. When we talk about the in general about the microvascular disease, there are certain consideration which should be kept in mind when we are talking about the microvascular complications of diabetes mellitus. Microvascular complications are specific to diabetes and do not occur without long-standing hyperglycemia in contrast to macrovascular disease. As I discussed in the last slide that macrovascular disease is due to development of atherosclerosis, and atherosclerosis behind atherosclerosis there is the combination of hyperglycemia, hypertension, and dyslipidemia. Even in the absence of hyperglycemia, there is some sort of macrovascular disease that can be found. But in contrast to that, in microvascular complications, hyperglycemia plays the main pivotal role. Without hyperglycemia, microvascular complications cannot develop. But that doesn't mean that other metabolic and environmental or genetic factors are not involved in their pathogenesis. They are undoubtedly involved in their pathogenesis, but the main role is played by hyperglycemia. Without hyperglycemia, macrovascular complications are possible, but microvascular disease is not possible without the presence of hyperglycemia, and definitely other factors like hypertension, environmental factors, genetics, metabolic other factors, they play a role in the pathogenesis of microvascular disease. This point should be remembered. Both type 1 and type 2 diabetes are susceptible to microvascular complications. Although patients with type 2 diabetes are older at presentation and they may die of macrovascular disease before microvascular disease advance because of other factors or metabolic syndrome. If the patient is hypertensive far ahead of diabetes mellitus, then he must have macrovascular disease at the time of diagnosis of type 2 diabetes mellitus, and the reason for his death may be a macrovascular event rather than the microvascular disease, which develops and which is dependent upon the presence of hyperglycemia, and its development starts when the hyperglycemia occurs in the person. In contrast to that, in type 2 diabetics, the macrovascular disease may even be present before the development of hyperglycemia in those patients who are susceptible genetically to develop hyperglycemia later on. That is, they are the part of metabolic syndrome. This is a little bit tricky, and if you have any confusion regarding it, you may contact me later on and we can discuss about this point. But you should always remember that type 1 disease, primarily the major reasons of morbidity are the microvascular disease, because the hyperglycemia is there for a quite a long period of time. But in contrast to that, in type 2 diabetic patient, in which the onset of type 2 diabetes is usually late, but due to genetic predisposition and due to other factors like hypertension, dyslipidemia, which are present even before the hyperglycemia starts developing, the macrovascular disease is present before the diagnosis of type 2 diabetes mellitus. This is why usually the type 2 diabetics, they die of macrovascular disease rather than microvascular complications. The duration of diabetes and the quality of diabetic control are very important determinants of microvascular disease, but because of other individual factors, do not necessarily predict their development in individual patients. We do see certain patients in our clinical practice which have disease for last 20 or 30 years, and they do not have such retinopathic changes as we do see in certain patients who are having the disease for the last 10 years. Definitely there are certain factors, most likely genetic factors are the most important one amongst them. If a person has a family member who develops retinopathy early, there are chances that the retinopathy will be developed in this patient earlier on as compared to the other persons in which the family history is not present. So there are certain other factors other than duration of diabetes. There are certain other factors which may also take part in the development of the disease. Duration of diabetes is definitely important, but quality of diabetic control, but it doesn't mean that that is the only solely determinants to development of or the development of microvascular disease. Different microvascular complications are commonly associated in individual patients, but their prevalence as a function of the duration or severity of diabetes may differ markedly. I usually tell my students that the eye is the only place where we can directly visualize the vessels in the body. If retinopathy is there, it is an indication of microvascular disease in the body, and it is a clear indication that microvessels of the person are involved, and nephropathy must be there, or it should be there at we can say, and there must be some sort of neuropathy as well. And In type 1 diabetic patients, background retinopathy is rare before 5 years of diabetes, but its prevalence increases steadily thereafter to affect over 90% of the patients after 20 years of the diagnosis of diabetes mellitus. After several years of diabetes, the risk of proliferative changes is about 3% of the patient per year, with a cumulative total of over 60% after 40 years. That it clearly means that the duration definitely has a clear cut association with the development of microvascular disease, but other factors should also be kept in mind, that this is possible that after 40 years of disease, 40% of the patient will not develop retinopathy. This is other way around, you can say that. And those 40% who don't develop retinopathy even after 40 years of the disease are the persons in which they are not genetically predisposed to develop retinopathy or nephropathy. Diabetic nephropathy affects 20 to 40% of the patients with type 1 diabetes mellitus, particularly those presenting before puberty and possibly those with an inherited tendency to hypertension. Because hypertension is one of the factor which definitely affect the development of microvascular disease as well, as that it affects the development of macrovascular disease. The progression of microvascular disease has a direct relationship with the control of hypertension. Type 2 diabetics are also susceptible to nephropathy. Over 40% of the subjects with type 1 diabetes mellitus survive more than 40 years, half of them without developing significant microvascular complications. Now, coming towards the pathophysiology of the microvascular disease. In diabetes, the microvasculature shows both functional and structural abnormalities. Amongst the structural problem, the hallmark is thickening of the capillary basement membrane. Wherever there are microvessels are present, the first structural change which is noted is the thickening of capillary basement membrane. The other functional problems which do occur in these patients, the main functional abnormalities are increased capillary permeability, increased blood flow and viscosity, and disturbed platelet function. So, early in the course of diabetes and precede organ failure by many years, these changes may be seen. Uh, when we talk about structural changes, that is the thickening of the capillary membrane. When we talk about the functional changes, these should be remembered, that is increased capillary permeability, increased blood viscosity, and increased platelet adherence. Basement membrane composition changes include increased type 4 collagen and its glycosylation products. Patients with poorly controlled diabetes have increased blood flow in many tissues, including skin, retina, and kidney. In the latter, this is reflected by an elevated glomerular filtration rate, which is usually the first ever sign of diabetic nephropathy in the patient. Increased capillary permeability is manifested in the retina by leakage of fluorescein and in the kidney by increased urinary losses of albumin, which predict eventual renal failure. And these are the hallmarks which are the basis of the diagnosis of these conditions. We do see leakage of fluorescein, or we do see leakage of blood into the retina by using fundoscope, and by determination of microalbuminuria or macroalbuminuria on urinary examination, we may predict the nephropathy in these patients. Both defects probably reflects a generalized vascular abnormality which may also involve the intima of the large vessels. Platelets from diabetic patients show an exaggerated tendency to aggregate, perhaps mediated by altered prostaglandin metabolism. Plasma and whole blood viscosity are increased, whereas the red blood cell deformability is decreased in the patients with diabetes mellitus. These defects, together with the platelet abnormalities, may cause stasis in the microvasculature that leads to increased intravascular pressure and ultimately tissue hypoxia. The production by endothelial cells of von Willebrand factor and endothelial derived relaxing factors, mainly nitric oxide, or also be abnormal in diabetics and could contribute to tissue damage. So there is increased blood viscosity, decreased blood cell deformability, increased platelet function, that all these three ultimately leads to increased intravascular pressure and tissue hypoxia that leads to damage. And the production of endothelial cells of von Willebrand factor and endothelial derived relaxing factors are also impaired, and that also contribute to the tissue damage. When we go further and see the biochemical abnormalities in the pathogenesis, prolonged exposure to elevated glucose concentration damages tissues by causing either acute, reversible metabolic changes, mostly related to increased polyol pathways activity and glycosylation of the proteins, or cumulative irreversible changes in the long-lived molecules like formation of advanced glycosylation end products, which are also called AGEs, on matrix proteins such as collagen and on nucleic acids and nucleoproteins. So both acute reversible changes and chronic cumulative irreversible changes takes part in the development of microvascular disease. In insulin independent tissues like nerve, lens, and retina, hyperglycemia causes elevated tissue glucose levels directly. The enzyme aldolase reductase catalyzes the reduction of glucose to its polyol sorbitol, which is subsequently converted to fructose. Sorbitol does not easily cross cell membranes, and its accumulation may cause damage by osmotic effect. Like in lens, that is the development of cataract. Early cataract is also a complication of diabetes and uncontrolled hyperglycemia. The reason behind that is the direct damage by conversion of glucose to sorbitol, which cannot be crossed through the cell membranes, and its accumulation causes an osmotic negative osmotic pressure, and the fluid is accumulated inside, and that causes damage, development of uh, cataracts in the patients with diabetes mellitus and uncontrolled hyperglycemia. In addition, increased sorbitol production is partly responsible for tissue depletion of myoinositol, a molecule structure related to glucose. Hyperglycemia itself also inhibits myoinositol uptake into the cells, and animal studies indicates that tissue myoinositol depletion may cause abnormalities on peripheral nerve function. So this was a brief introduction of the pathophysiology and biochemical basis of damage in the microvasculature of the body that is caused by persistent hyperglycemia, and that the thing which are to be remembered at the end of this lecture are: number one, that microvascular disease is dependent not only on hyperglycemia, but definitely other factors are also involved, and even in absence of hyperglycemia, those factors may continue causing macrovascular damage due to the development of atherosclerosis. And those factors which are related are hypertension, dyslipidemias, and other causes, other factors which are the part of metabolic syndrome. But microvascular disease is not possible in absence of hyperglycemia, even if the hypertension and dyslipidemia is present on those patients. But definitely, once hyperglycemia is there, these factors may aggravate the rate of development of these complications and shorten the duration before the patient is remained healthy. But these things to be remembered, that microvascular disease is developed only in the presence of hyperglycemia, and macrovascular disease may precede hyperglycemia in certain patients with type 2 diabetes mellitus, which are also suffering from metabolic syndrome. This is the reason why type 2 diabetics die usually of macrovascular disease rather than microvascular disease, because hyperglycemia develops late as compared to the other factors of metabolic syndrome in these patients. The other thing which should be remembered is the microvascular disease dependent upon two types of changes in the vessels. Number one is the structural changes, and number two, the functional change. The structural hallmark is the basement membrane thickening, which is usually seen in histopathology samples, and the functional problem which is seen in these patients is increased permeability, increase in the blood viscosity, and increased aggregation of platelets. So these things should be remembered And it also will be remembered that the tissues which are not dependent of insulin for the absorption of glucose, those are the direct effective of hyperglycemia. In on those cases, the reduction of glucose to fructose and accumulation of fructose intracellularly, which causes osmotic damage, is main biochemical problem which is seen in these patients. The other problem which is seen is the hyperglycemia itself also inhibits myoinositol uptake into the cells, and certain animal studies indicate that tissue myoinositol depletion may cause abnormalities on peripheral nerve functions. So we end here, and in next lecture we will very briefly go through two important microvascular diseases, that is retinopathy and nephropathy. So Allah Hafiz.